talking about might not be applicable to all of you, especially if you're diagnosed as an adult. But I think, as Jessica and Dr. Peters were saying, sometimes just bringing up the conversation of epilepsy might get you into a conversation with someone who has a child. And so being abreast of some of the updates on what we can do for children with epilepsy as well can be useful to everyone. But certainly if any of you are caregivers or family members or yourself have epilepsy in childhood, I hope that you can learn something today and share that information with others. Yes. So, and I'm a pediatric epileptologist and neurologist. I work up at the University of Utah as an assistant professor on faculty in the School of Medicine. And then recently we've opened a comprehensive epilepsy clinic at Primary Children's Hospital. And so I've been tasked with being the medical director of that, which has been a real pleasure and learning curve. And I don't know how to use a Mac, but I'm trying. Okay, I have nothing to disclose. The only thing I like to update is that some of the devices and medications that we use in the pediatric realm are not FDA approved for those under 18, and so might be considered off-label. So today I was asked to talk about what's new in pediatric epilepsy, and I think I just wanted to go over some basics in terms of medication, surgery, and genetic testing. And just updates in those three realms. So we'll be going through each of those. But to start, I thought I'd give a little bit of background on some statistics in epilepsy in children. So 6 in 1,000 children have epilepsy in the United States. That means that nearly 500,000 kids in the US have epilepsy, active epilepsy at any time. And that averages out to about 5,300 in the state of Utah. So if anyone is feeling more isolated, you are certainly not alone. More than half of children will outgrow their epilepsy by adolescence. It takes 2 to 5 years. That's a definitely different statistic than in the adult population usually. And it's a great statistic unless you're in the other half that doesn't outgrow it. And then that can be really challenging too. Some epilepsy syndromes are only diagnosed in children, and we'll go over just a few of those basics that are unique to the pediatric world. And then why do kids get epilepsy? Well, half the time we don't know, and that's really frustrating. And I think that's why it's important that we're continuing to do research to try and understand this. Some of the known causes are also similar to the adult population: brain injuries of various kinds, whether that's from an infection or lack of blood flow or a stroke, abnormal brain development, brain tumor, or a genetic condition. But as I mentioned, a lot of times we don't know. This is a really old slide, but it's kind of the best schematic that's been published about the various age ranges and then the different types of epilepsy that can affect kids of different ages. And so it's a little bit confusing, but the smallest circle is those that are 1 month diagnosed in the first month of life. Many of those stand for maybe a benign familial epilepsy, but others can be more serious in the neonatal period. Epileptic encephalopathies, meaning they're having so many seizures, it really impacts how their brain is able to grow and develop. And then the lighter blue circle or donut expands out to include those that can be diagnosed in the first year of life, and then expanding out into 10 years of age, and then just outside that bigger donut is the adolescent onset. And so epilepsy can be diagnosed at any age. There's different types of epilepsies that impact different children of different ages, but not everyone falls into exactly one of these categories, but there's lots of different ways that epilepsy can present at different ages. And I think that's the main important part to remember. The other thing that we have to remember, yes, no. Oh, yes, that was from a previous presentation that I was going to go into each of those in more detail, and I'm not going to do that today. Thanks for identifying that. No, I think those were, I will say, no, those are, I didn't even realize they were still on there. Thank you. Some of those are the more common ones though, and that's why I was going into more detail. And so let's just say those are the more common conditions. So for example, in adolescents, juvenile absence epilepsy or juvenile myoclonic epilepsy, some of the benign Rolandic epilepsy is now called self-limited epilepsy with centrotemporal spikes. We like to make things as long as possible in the name. But yeah, so those are some of the more common ones that we often go into more detail on. This is the other schematic that I think is important to keep in mind, that epilepsy is just one part of it in terms of children, but also adults. These are called comorbidities or associated conditions that are more commonly seen in children with epilepsy. A child with epilepsy will not have all of these. And just because someone has autism doesn't mean they'll have epilepsy or vice versa. But I think there is an increased risk of these conditions in children with epilepsy, and being aware of those aspects, even in the setting of good seizure control, is really important to their growth and development and learning. And so being aware of some of those to consider that even if seizures are diagnosed and maybe controlled, being aware of attentional issues or neurodevelopmental differences, mood challenges, headaches, migraines, sleep disturbances, so that we can help treat the whole person. The management of epilepsy in children is very similar to adults. You start with an anti-seizure medication. Approximately 2/3 of children are going to be well controlled on the first or second anti-seizure medicine that they try. That does leave about 1/3 of children, and so that are not well controlled on the first or second medicine that they try, and they're considered to have intractable or drug-resistant, medication-resistant epilepsy. And that's when they might have to start looking into alternative therapies like ketogenic diet, epilepsy surgery, or neuromodulation. Again, sometimes we have to think outside the box, and we use things off-label that have only been tested and studied in the adult population at that time. But certainly within as safe of an option as we can, we try to offer that to children if it seems like the best thing to do. And so if you think about that 6 in 1,000 kids in Utah are afflicted by epilepsy, that means that up to 2 in 1,000, so a few in potentially every high school, for example, might have medication-resistant or intractable epilepsy. Okay, so now I wanted to actually get into the talk about updates in pediatric epilepsy management. So I was gonna talk next about updates on anti-seizure medication, and just let you know that a previous term that we used was anti-epilepsy drug or anticonvulsant, but the term we more often use is anti-seizure medicine. They're all interchangeable and it's not wrong. I like the term anti-seizure medicine, and this was like a preferred suggestion by the International League Against Epilepsy. To me, it makes a little bit more sense because a lot of our medications are working on the seizure, not necessarily the disease itself. And so it's anti-seizure, not necessarily anti-epilepsy. And then I think medication rather than drug just sounds better, especially in kids. Drugs have more of a negative connotation. So, and you know, I guess what is an update? 2019 seems like somewhat long ago, but with the pandemic in there, maybe it seems like yesterday. So there's been at least 5 new anti-seizure medicines or newly approved indications in the pediatric population, and 2 new rescue seizure medication options that I'll just want to make sure that you know. This is a basic history of anti-seizure medications over time. The font is very small on the bottom, sorry, but there's so many medications. So I don't expect you to be reading these and knowing, but just knowing that since the 1990 era, the number of 3rd generation anti-seizure meds has just really expanded and continues to expand. And so I think a lot of people come in with a stigma or concern about the side effects of anti-seizure medications, and certainly that's a valid concern, but people are working really hard to expand the options, what mechanisms we might be able to use, and that includes in the pediatric population. So we're very thankful for that ongoing advancement. These are the 5 that I wanted to make sure you knew about in case you're considering other options for medication treatment of a child with epilepsy. Cannabidiol, the brand name's Epidiolex, was approved in 2018 for children with Dravet syndrome and Lennox-Gastaut syndrome, and that was expanded FDA approval in 2020 for those with tuberous sclerosis complex in children 2 years of age and older. Again, sometimes we can use it off-label in those with intractable epilepsy, but it can be variable. Cenobamate, or the brand name Xcopri, was approved in 2019 for focal onset seizures. I included this one because it's new and but it's still only approved in children 18 years of age and older, but we have been able to get it approved in some children, especially older children, and so it might be worth asking your neurologist about if you've tried other medication options. Fenfluramine or Fintepla was approved in 2020 for those with Dravet syndrome, and then in 2022 for those with Lennox-Gastaut, and these are both more severe forms of epilepsies. It's more common that will be the first population in the pediatric world that's tested for approval. And then sometimes over time, it gets expanded approval. But those are both for children 2 years of age and older. Ganaxolone, I'm terrible at pronouncing the brand name. Sorry if a rep is here, you can let me know to tell me. Was approved in 2022 for children with CDKL5, a genetic form of epilepsy for those 2 years of age and older. And then more recently, Daybue was approved earlier this year for trofinetide is the generic, Rett syndrome associated symptoms, including those who have epilepsy for those who are 2 years of age and older. Other things you should know about: everyone with epilepsy should have a rescue plan. And sometimes, as we know, seizures might cluster or be prolonged and need a rescue medication. The best, fastest way to get it absorbed is important. And previously we've had rectal suppositories or dissolving wafers or trying to compound a tablet and stick it in the cheek with a stick and not get your finger cut off or somehow. And so they've done some trials on nose sprays. And more recently, we have had approval of these 2 rescue nose spray options for those having a prolonged or cluster of seizures. Midazolam, in the form of a brand name Nasolam, was approved in 2019 for kids 12 years of age and older. And then a nasal spray of diazepam called Valtoco was approved in 2020 for children 6 years of age and older. And as a reminder, Epilepsy Foundation website has some seizure action plan options that you can give for schools and caregivers, including daily preventive medications, but also rescue options and what to do during a seizure. So check that out if you weren't aware of it. Okay, so next we're going to move on to advancements in epilepsy surgery. Dr. Peters is going to be going over a lot of this in more detail in her next talk. But I think so I'll be sort of moving through these slides quickly also to keep us on time. But I think it's most important for you to realize that surgical options and device options can also be used in kids. And I think that's really hard to hear as a parent. But it's really important to know that there's options and we don't have to just keep trying medications if that doesn't seem to be working for their child. So these are reserved for those with intractable epilepsy. Like I said, that's about 1/3 of the pediatric population where they're not responding to the first or second medication. And that's because it's not working to control seizures, not stopped because of side effects. But for those with intractable or medication-resistant epilepsy, looking at these surgery options is really important to know. We've been fortunate that with advancements in surgical techniques, there's less invasive options as well to help diagnose and understand. And again, Dr. Peters is going to go into those details, but there's something called stereo EEG that is a less invasive option. And then there's expansion of neurostimulation devices that we'll talk about, VNS, RNS, DBS, for both generalized and focal epilepsies. that are available for use in children as well. So a stereo EEG helps us identify where a seizure starts in someone with focal epilepsy. These are some options. Hopefully you're not too squeamish. I tried to make it not too gory, but on the left, you can see how they'll, in the operating room, try to identify the best target and approach for identifying the seizure. And this is done with a neurosurgeon and neurology team. And then, for example, at our institution, we use ROSA. And so these are some images of some of the electrodes that actually go into the brain, not just sit on top of the scalp to try to identify where a seizure is coming from. This is a really important option compared to what we used to do, which was the subdural grid on the left side of your screen, where they had to remove a larger portion of the skull and open up the brain, and the risks and complications were much higher. So having a less invasive option that's also available in kids has been really important in helping us try to understand and treat the more severe epilepsy cases. There's improved safety, lower rates, as I mentioned, of bleeding or infection, and it also allows for a broader coverage. And so people who previously had a bigger network of where their seizure was coming from, we might not be able to offer surgical intervention if it was too broad, and we can expand that now, and that's true for children. Neurostimulation devices are options when maybe resective surgery or removing part of the brain isn't an option to treat someone's seizures, or if that has failed. And vagus nerve stimulation, responsive neurostimulation, and deep brain stimulation. And you can see in the schematic, it's kind of an artistic interpretation of faces, but I kind of liked that they showed them right next to each other of where they go in the body to try to target. And I think a lot of the studies and data that comes out is on the adult population, but we do all of these in children as well. This was an updated, this includes adult and pediatrics, but a recent paper that came out talking about for patients with intractable drug-resistant epilepsy, finding a reduced risk of early death by approximately 80% after epilepsy surgery, and decreased by 40% in those with vagus nerve stimulation compared to medication-only management. So while it is intimidating to think about, especially in the pediatric world, it's important to consider options for both safety and improved seizure burden. So the VNS, as I mentioned, Dr. Peters will go over a lot of these in more detail, but that's been approved or since 2015, sorry, it's been older than that. It has some updated auto stimulation techniques. It has day-night programming, and then a prone. So if you're laying face down, body position as a biomarker for SUDEP. So it can give us a little bit more information and target different seizure burden. So for some people who have increased seizures at night compared to in the day, we can do different settings. This is what it looks like when we're programming it on the tablet. And that's approved for kids 4 years of age and older, which seems really small to have a generator implanted in their chest with a wire up through their neck to the vagus nerve for their epilepsy. But it's important to keep in mind even for our younger patients. There's ongoing studies in the pediatric world on VNS. And so this one, we're still waiting for kind of the results of it, but they enrolled ending in 2021, and they'll be following these patients for 5 years. A third of them are children, and they are looking at outcomes associated with VNS. And so we're all looking forward to getting some updates from the core VNS study. Responsive neurostimulation, or RNS, was originally FDA approved in 2013 for adults with intractable focal epilepsy. We got some updated information on how to utilize it with an MRI machine in 2020. And then in 2021, they are undergoing it was approved for investigational device exemption for those with generalized epilepsy in the adult population. I won't go into the details, but there's been some updated results that Dr. Peters will go over too in terms of if that's useful for patients. And that is all adult data, but they've found very similar numbers in children as well. There's increasing clinical trials for kids with RNS as well. So right now it's being done across the nation, but it's off-label. And so it's really important to be able to expand that into our younger population. And so these are a few of the different trials: Nautilus study, Lennox-Gastaut syndrome study, and the response study, to look at how RNS might be helpful in the pediatric population as well. And then finally, deep brain stimulation, which is probably used more in Europe than in the US, at least until recently. That was approved for intractable focal epilepsy in 2018. They target a deeper structure of the brain, and that's for children 18 years, or sorry, for people 18 years of age and older. But again, they are fortunately looking into some clinical trials and studies to look at how this might be used in the pediatric population. And again, it can be used at certain institutions off-label. So something to ask your neurologist about, but we're continuing to learn more and more about these in the pediatric world. Okay, so then I'll be moving on to my last section, which I'll try to do quickly to keep us on time. Genetic testing for people with epilepsy. I think, as I mentioned earlier, only half the time do we really get an understanding of why someone has epilepsy. They might have a normal brain MRI and no family history. They've not had any developmental challenges. And so that why question is really burning for a lot of families and patients, but also for us on the caregiver side, that trying to understand, is there something different we should be doing for patients to help understand? And I think looking at the genetics of epilepsy is a really fast moving field. It's been focused a lot on the pediatric world. It shouldn't be, though. I think that's expanding into the adult population more and more now. And hopefully insurance companies, is this recorded? Yes. Hopefully insurance companies will continue to follow suit. I'll just end there. And so I think if we could better understand the mechanisms of why someone might have epilepsy, it might help guide our treatment and management. So that maybe that's the missing piece of the other 50% is, and we're still trying to figure that out. When someone gets a genetic diagnosis, certain times it can change the management strategy. It can help with the prognosis. Are they more likely or not to outgrow their epilepsy? It can help with family planning for younger, or like a, young adult. As I mentioned, it's not just for children, and it's not just for those with a strong family history, and it's not just for those with severe intractable medication-resistant epilepsy. Most cases of epilepsy are considered de novo, meaning it's a unique genetic variant to that person. It's not heritable, meaning it's not passed down through family members. And so even when people say, well, there's no family history, why would we do genetic testing? Well, we don't know. And all of us have some variants that may or may not cause disease. And so it's important to still look. Ideally, this should be guided by your neurologist or a genetic counselor or a geneticist or someone who can help you understand the results if something comes back. There's many different options. And again, I won't go into the details of them. It's more that you should know they exist and ask about them with your care team. So ranging from more broad genetic testing, karyotype, chromosomal microarrays. There's epilepsy gene panels. So that's the most common thing that we do. There's something called Behind the Seizure program, where children under the age of 8 can get a free epilepsy gene panel that looks at about 300 genes associated with epilepsy. Again, there could be thousands and we just don't know them all. So we need to continue to expand that, but that's free under the age of 8. And you should ask about it if that population, if you have someone with epilepsy who's under 8. Whole exome sequencing and whole genome sequencing is much more extensive, expansive genetic testing, but there's ongoing research and even insurance approvals that are allowing us to understand more and more, looking into the why. I think this is an area of medicine that's rapidly expanding. There's definitely some things getting into the news about different genetic treatment options. And so this would be disease modifying therapies for epilepsy. And so this pyramid, I'll walk you through it. At the bottom, we might be able to understand, well, certain genetic conditions respond better to certain anti-seizure medicines. Maybe we don't know exactly why, but if you have this type of epilepsy, you should probably try this type of medication. And then that expands into, prescribing or avoiding certain medications and certain genetic conditions that result in epilepsy. But I think what we're starting to get into is that top of the pyramid, where therapies might be directly targeting protein dysfunction from a genetic variant, or the mRNA, or the actual gene defect. So are we starting to get into not just anti-seizure medicines, but these would be actually anti-epilepsy medicines, looking at the core of the cause. We can't come up with the treatment if we don't know the cause. So we still are back in trying to figure out the underlying cause for some of these genetic epilepsies. But this is why it's so important. If we can better understand the why, can we have better outcomes and treatment options that are more curative rather than symptom management. Oh, sorry, I did go through some of the examples. So ethosuximide, for example, is like a medication we commonly use in absence epilepsy in kids. Fenfluramine is a medication that we more commonly use in patients with Dravet syndrome, and that's a specific genetic explanation. Everolimus is a medication that targets the protein dysfunction in tuberous sclerosis. And then there's different mRNA injections that you can do, and that they're starting to research on patients with SCN1A related genetic defects causing epilepsy. And we don't have curative forms of this, but that area is rapidly expanding. So I think I don't expect any of you to remember any of this, or but I think knowing that there are gene therapy trials out there, for example, in patients with Dravet syndrome or CDKL5 related epilepsies, the ASOs, the antisense oligonucleotide studies also for Dravet syndrome, targeting these different areas and different forms of genetic epilepsy is really exciting on our side, in a field where it feels a lot of times like you're putting a Band-Aid on. And we want to really fix it, and so do the families. And so this is exciting to be able to expand into some of these options moving forward. Okay, so I'll just end with a quick summary that things are ever changing in epilepsy, and that expands into the pediatric world as well. That there are some updates on anti-seizure medications, both in terms of the terminology, how we talk about it, but also the options for daily prevention and rescue medications. We have advancements in epilepsy surgery that you'll learn more about in the next talk, both for the diagnosis of epilepsy and the management of it. They're less invasive and reaching a broader patient population and decreasing the scarier risks of epilepsy in those who are more severe. And then we have expanded genetic testing for epilepsy. Again, this is not just for the severe epilepsy cases, and there's new gene therapies on the horizon, so let's not lose hope. Thinking about what you can do and with this information, again, just share with a loved one that there might be different anti-seizure medication options if what you're on isn't working. Reconsider surgical evaluation at an epilepsy center if medications aren't working. Even if you've been previously told that's not an option, see if there's anything that is now available that would change that answer. And then continue to keep your eye out for gene therapy options that might be guiding management and expanding treatment options as we move forward. Certainly, Epilepsy Foundation of Utah has shared a lot of the great local resources for support, and also ways to get more information about things that are changing in the scientific realm, both in terms of treatment and management options, but also support. Selfishly, Child Neuro Chat is a podcast I do with one of our epilepsy nurses. We haven't recorded a new episode in a few years though, but 2024, it's going to be resurfacing. And then, yeah, especially for the pediatric world, feel free to reach out to us up at Intermountain Primary Children's Hospital and University of Utah for that new comprehensive epilepsy center. All right. I think we're going to be holding some questions for the end, but if while the next speaker is coming up, I won't be able to stay for the whole visit. So if anyone has a question, feel free to ask now or grab me on the way out. But yes. Oh, well, I think this is recorded. Is that right? Yeah. Great. Thank you. Thank you. I'll give you that piece. There, thank you. All right. That again. All right, we're good for a second there.